Here we are illustrating a case of Holmium laser enucleation of the prostate for a 160 gram prostate. I'm doing here the Bloc technique. We start with the cystoscopy, looking into the bladder, and then the landmarks, which is the sphincter and the contour of the prostate, which is very important actually, because sometimes the contour could be skewed. For example, here the medial lobe is kind of more to the right side rather than the middle. Again, when you do and start to do more of those cases, you can adjust your techniques every now and then, which is something that's probably good to end with a technique that suits you or suit the case sometimes. Sometimes I start again anteriorly at the bifurcation of the two prostate lobes, and sometimes I start at the just proximal to the buromontanum, like in this case. I start with the horseshoe incision, and the good thing here, or the rule here, is just to deepen your incision to the capsule, and always you have to know where is the landmarks that kind of separate the prostate adenoma from the sphincter. For example, in this case, the prostate adenoma is just far kind of distal to the buromontanum and very close to the sphincter. So you have to go back sometimes, or actually it's a good technique to go back every now and then during the case just to understand your landmarks and start your planes in order just to save the sphincter and get the whole adenoma enucleated. So for example, here, after we start the horse, I start expanding my incision to the anterior aspects, to the bifurcation of the both prostate lobes anteriorly, in order to connect the planes together and have a circumferential kind of incision around the adenoma that serve as the landmark and the distinction point between the sphincter and the prostate adenoma. So it's probably that's the critical part of this procedure, and I always tell my trainee just to, usually you have to be patient here. You have to be patient, you have to be precise and take your time, and always look at your landmarks and follow the planes and be cautious for the sphincter. This patient was on retention on indwelling catheter for the last 2 months with the maximum PPH therapy when he first came to my clinic. Here we could appreciate the capsule from the actual adenoma, and here where you should be most of the time at the junction between the adenoma and the capsule in order to peel the adenoma easy and roll it over. With the Bloc technique, usually what you're basically doing is just rolling the adenoma retrograde manner to the bladder. So you should reach the capsule, or the junction between the adenoma and the capsule, in order to peel very well. Although I don't use any mechanical or forces to push the adenoma, I just let the laser to do the job. but again, it's much easier to reach that plane in order to have the rollover be more smooth and very quick. Here, after creating a good plane on the or the 6 o'clock position, we go kind of laterally to include all the adenoma as possible on both sides laterally, so connect planes together. Again, I always do or make a very wide roads or routes here. I don't dig deep and just leave the plane. No, I try to be very wide, make a very wide incisions in order just to keep my plane going, because sometimes if you dig deep, you might miss your plane if you come later just to connect it with other planes. So when I start on one side, I usually deepen it enough and widen it enough so I could tell where I was later, and it's easy to connect with connect planes together eventually when you have a wide incisions and very good, well created planes. The goal here is to reach the 12 o'clock anteriorly from both sides in order to have a very wide plane circumferentially and have the whole adenoma kinda separate from the capsule circumferential. So again, you have to be more patient. Sometimes you feel that you want to kind of curve early, just go back and block. The planes sometimes just are more eluded and you need to go actually more perpendicular rather than just curving. It's not the time to curve here or there. So just have your perspectives and look back and see if you have all the adenoma with you or not. Especially with big prostates, it's easy to lose planes, so you have to keep oriented, and that's what make it more successful and also time effective. When you feel kind of going more toward the capsule, that's not a big deal. Just readjust your plane and come closer to the adenoma. Especially with big prostate, the contour sometimes can be even all over. So just readjust your plane and come closer to the adenoma. And you could tell here when you have some sharp tissue, spongy tissue, that this is more of adenoma, sorry. So just keep close to the adenoma, but not too much into the adenoma, because you don't want to create a plane through the adenoma, and that's gonna be very tedious and difficult to create all over. Again, here's crossing the midline anteriorly to connect the right and left planes, and then carry the incision kind of anteriorly to the bladder neck. Here I realized that the plane is kinda lower than it should be. Again, it's not a big deal, especially with big prostate sometimes. the contours could be skewed. So I readjusted my plane to include more adenoma anteriorly. So when you get in a wrong plane, just go back to landmarks and readjust your plane. Here we back to the correct plane, and we know that when we reach the longitudinal fibers of the bladder neck and cutting through the mucosa, which is a good landmark actually to sweep back bilaterally between the capsule and the adenoma. So when you reach those fibers, you know that you are the correct plane, and now you could widen your plane bilaterally till you reach the previous incision at 3 and 9 o'clock on both sides. Same maneuver on the left side, the lateral aspect between the capsule and the adenoma. And here, what I do, I kinda take the laser from the bladder neck between the capsule and the adenoma and try to sweep medially in a way that kinda squeeze the adenoma in the middle. So I make a very wide incision on the lateral aspect, so I could kinda squeeze the adenoma in the middle and release it completely on the lateral side. Here when I reach the bladder neck bilaterally, I try to leave some adenoma back, especially at the 6 o'clock, in order not to undermine the bladder neck. Here when reaching the bladder neck on both sides, again we have to keep the scope really under the prostate, lifting the prostate up while the razor fiber is working. And again, smile incision. Try to be very cognizant about the location of the urethral orifices. And shortly I will probably flip to the normal scope position, 6 o'clock, in order to finish the smile incision. And by doing that, I can avoid injury or possible lasering on, here I'm flipping, to kind of try to avoid lasering close or on the urethral orifices. So that's the idea of flipping here, after I made sure that the prostate is completely flipped into the bladder and no need to carry it further. Here we're finishing the nucleation. Again, we have to continue with the contour of the prostate, try to be in the middle, be cognizant about the location of the UOs. Here nucleation is finished. Now look for the urethral orifices. Here's the first one. Here's the left side. Looks good. Now we do some hemostasis and tissue trimming in order to move for morcellation. Here's the final fossa. The sphincter very well preserved with good mucosa over it. That's the goal. Here we start the morcellation part. Again, when we do morcellation, we have to be patient too, because that's an easy but could be a tricky part of the procedure. Because if a bladder injury happens during morcellation, it's not something that you would like to have at the end of good enucleation of the prostate. So you have to be very, very attentive during morcellation. Make sure that bladder all the time full. Sometimes I may take some breaks of suctioning just to give some time for the irrigation fluid to fill the bladder more. For probably I can stop for a few seconds, 5-10 seconds, fill the bladder more, make sure that it's well filled, extended, and then resume morcellation. Procedure time was 85 minutes. Patient was able to pass the trial void next day. Thanks for watching.